in the next months. So I think we can start.
Yeah.
Massimo, do you want to?
Yeah. Okay. Welcome everybody. It's a pleasure for us to have you here. And the fighters on the ring this afternoon will be Walter Biffl and Pradeep Navsaria, and they will fight about taking out the or preserve the blunt or the injured spleen. May the best man win. So ready to start.
I think we can follow the list in the program. So, or if you want, you can decide even you, Walt or Pradeep, who would like to start this conversation regarding the spleen.
Okay. Was I first on the list? I'm happy to go ahead.
Okay.
All right. I'll share my screen. Okay. Well, I first want to thank Federico Coccolini and Professor Karugi for putting this together. This is a wonderful series and allows us to meet virtually where we couldn't otherwise. We're going to be discussing the management of splenic trauma, and I was given the task, the easy task, I think, of defending splenectomy. My colleague, I won't call him my adversary or my opponent, he's my colleague, Professor Navsaria, works in a very beautiful place. I visited Cape Town once. I didn't see the hospital, but a gorgeous place to go to work every day. The Groot Scher Hospital sees 12,000 patients per year for trauma, among the busiest trauma centers in the world, and surgeons come from all over the world to refine their operative skills. And the professor's written hundreds of papers on trauma, and I got some insight about how he thinks by reviewing what he's written. One of the principles that I agree with is keeping it simple, keeping the management of duodenal gunshot wounds simple. Extraperitoneal rectal gunshot wounds, management made simpler. Penetrating wound to the neck, no problem. Put a balloon catheter in it. Stabbed in the heart, no problem. Pericardial window and drainage. After operating on so many trauma patients all his life, I can understand that he's lost interest in operating on patients. Many papers supporting non-operative management, liver gunshot wounds, abdominal stab wounds, more on liver gunshot wounds, kidney gunshot wounds, pelvic gunshot wounds, kidneys again, abdominal gunshot wounds. Oh, shot through the esophagus? That's okay, we can watch it. Abdominal gunshot wounds, penetrating thoracic injury, liver, penetrating abdominal trauma. What you don't see in there is anything about non-operative management of splenic injuries. So he must support splenectomy. So I guess the debate's over, but we'll keep moving on and try to put some context to what we're talking about today. Just a brief review of the history of splenic trauma. Splenectomy for many years was the standard management, but people figured out that not having a spleen could be disadvantageous for the patient, making them more susceptible to infections by encapsulated organisms and their dreaded phenomenon of overwhelming post-splenectomy infection. And this led to interest in preserving the spleen. So in the 1970s, 1980s, there was a focus on operative repair of the spleen and in some cases, autotransplantation of splenic tissue to aid in the immune response. And then of course, the non-operative management of splenic trauma was introduced first in children. We usually experiment on the children first and then take it to adults. So the Toronto Hospital for Sick Children published a series. And today, as reflected in this series from the National Trauma Data Bank, the large majority of splenic injured patients are managed non-operatively. In the current era, at least in the US, nearly 20% of splenic injuries are managed with splenectomy, only 3% with splenic artery embolization, and about 2% still undergo splenic repairs. So the playing field today is to discuss splenectomy and splenic angioembolization in grade 3 to 5 splenic injuries. And we're going to ignore the hemodynamically normal patients because non-operative management is the standard. So I've selected a few populations and issues of interest where I think the debate really focuses. And they're listed here. First, the hemodynamically unstable patient, the transient responder, the patient with a contrast blush, and the patient with grade 3 through 5 injury with or without contrast extravasation. Now, first, in the hemodynamically unstable patient, we like the simple approach. The professor likes it, I like it, splenectomy. That's the accepted treatment. This recent review of patients from the National Trauma Data Bank reinforces that. That is how they're being managed. 95% of hypotensive patients with grade 4 and 5 injuries in this series were managed with splenectomy. They allow that if the interventional radiology resources are immediately available, then it is permissible to go for angioembolization. There was no mortality increase in this study, but of note, the infection rate was 3 times higher in the patients who were embolized. Sorry. Now, the issue of the time to angioembolization is that last study indicated if it's immediately available, it's good. In this study from the American College of Surgeons Trauma Quality Improvement Database, every hour delay in angioembolization was associated with a significant increase in mortality. Now, the next category of patient are the transient responders. This paper titled Hemodynamically Unstable Patients, but when you read the paper, they were transient responders who had a CT scan and then went on to angioembolization. And the authors noted here that this was a safe and effective procedure for managing hemodynamically unstable patients who respond to fluid resuscitation. Now, this concept of transient responders is a little confusing to me. The definition of transient is lasting only a short time. So when the transient responder becomes hypotensive again, now they are unstable, and I think they should have a splenectomy. If they respond and remain hemodynamically stable, they're a durable responder. The problem is you don't know until it's too late. So I think that transient responder, that's not the time to go off to the interventional radiology suite. Now, we learn a lot by looking at failures, and Professor Peitzman from Pittsburgh had published a large series of splenic injuries with the Eastern Association for the Surgery of Trauma. And in this paper, they focused on the patients who failed non-operative management. And they looked at them in 3 categories: those who were always stable, which was about 44% of the patients; those who responded to initial resuscitation, about 30%, and those who remained unstable, which was about 25%. The patients who were stable and failed non-operative management, only 3% mortality in that group. The responders who failed had an 8% mortality, but the patients who were unstable and non-operative management was attempted had a 37% mortality. So we are putting lives at risk by doing things other than splenectomy in these patients. They note that 30 to 40% of the patients who had unsuccessful non-operative management were selected inappropriately with hemodynamic instability or an initial misinterpretation of diagnostic studies. So we need to be very careful about selecting patients for non-operative management. The contrast blush has been associated with failure of non-operative management and consequently is an accepted indication for splenic arterial embolization. But we also know that some blushes are transient, and the presence of a blush alone is not necessarily an indication or a requirement for angioembolization. Now, the non-operative management does have a low failure rate. And in this paper focused on grade 3, 4, and 5 injuries, and they note that grade 1, 2, and 3 injuries all have a very low failure rate. And we should reserve embolization for the high-grade injuries, that is 4 and 5, or patients with visible vascular pathology or active bleeding. Now, this systematic review and meta-analysis was performed by the group in London. And in this paper, they looked at 33 different studies enrolling nearly 7,000 patients. For all grades combined, there was no difference in failure of non-operative management and mortality, hospital length of stay, or blood transfusion. But morbidity was significantly higher in patients treated with embolization among all grades. When stratified by grade of injury, angioembolization significantly reduced the failure rate of non-operative management in patients with grade 4 and 5 injuries, but had minimal effect on those with grade 1 to 3 injuries. And that is depicted here. This figure demonstrates the significance in the grade 4 and 5 injuries, and in this graphic as well. So the angioembolization and non-operative failure rates. So grade 4 and 5 injuries are really the focus. Now, our colleague, Catherine Arbuche in France, recently published this paper. This is a really nice study because there's very little literature really looking at the ability of angioembolization to reduce the rates of failure. And in this study, they took patients who did splenic artery embolization prophylactically compared with those who had surveillance and embolization only if necessary. And they found that the endpoint was the presence of 50% viable spleen detected on a CT scan at 1 month, and that was not different between these groups. So either strategy is acceptable according to this study. So what this indicates is that taking patients prophylactically for angioembolization does not offer any advantage. Now when I worked at Brown University many years ago, we had a lot of failures of non-operative management, and we looked at the rates, and what we found was in patients with grade 3, 4, and 5 injuries, we had after embolization failures of non-operative management in 40% of these patients. And the failure related also to the finding of the degree of hemoperitoneum. So moderate or large hemoperitoneum was associated with failure also, if you combine those, in about 40%. So we found that 43% of patients with high grade injury and moderate or large hemoperitoneum failed even after angioembolization. Embolization was more likely to fail if there was active extravasation at the time of arteriography. 59% of them ultimately required splenectomy. And of the embolization patients who experienced any hypotension, nearly 60% ultimately required splenectomy. And this is a theme over and over, that the failure is often related to poor patient selection. And failure is not a benign problem. In this study from the Texas Trauma Study Group, arterial angioembolization leads to effective non-operative management in many patients, but transfusion in the first 24 hours is independently associated with failure. So that should be a sign to the clinician that they may need a splenectomy. Patients who required a delayed splenectomy suffered more complications and had a higher hospital length of stay. And most importantly, failure was associated with a 4-fold increase in mortality. On the other side, in addition to the patient outcomes, is the cost to the healthcare system. And what they found in this cost effectiveness analysis is that non-operative management, of course, is the dominant strategy. The splenic angioembolization is not favored unless the probability of failure of non-operative management is greater than 70%. So for grade 3 to 5 injuries, non-operative management without embolization yields more quality adjusted life years, and it's the most cost-effective strategy. So this is the algorithm from the Western Trauma Association. And this, of course, any unstable patient with positive FAST is going to the operating room, and any failure of angioembolization. And there's only one category where it's really recommended, and that is a patient with grade 4 and 5 injury and a contrast blush. And yes, otherwise it's a consideration, but very low consideration in the patients with grade 1 and 2 injuries. So in conclusion, splenectomy should be performed in all unstable patients, and it saves lives. Splenic embolization should be reserved for more stable patients, and it can save spleens. They are complementary and should both be options. So I've gone easy on the professor because tomorrow's his birthday, and I didn't want to take advantage of him as I had the superior side of this debate. And I thank you for the opportunity to participate in this.
Thank you very much, Walt, for this really insightful and complete presentation regarding the usefulness, and really balanced, trying to see all the positive and negative aspects of the splenectomy. So now we can hear Pradeep in order to have his vision of the opposite side of the medal regarding the embolization and then the trying to save the spleen.
Oh, I have to stop sharing. Sorry.
Okay.
I forgot that part.
So Pradeep, you can proceed to share.
Okay, I will. Okay, first of all, thank you for the invitation. Walt, thank you for your talk. I completely agree with everything you have said. We can stop just here and go home now. Okay, this is where I work. This is Groote Hospital. Walt showed you an old picture. That's the old hospital at the back there. And somewhere there on the first floor, the first heart transplant was performed just about 50 years ago. This is the new hospital, and I'm currently talking to you from a room somewhere over there. So if I remember correctly, the talk was actually splenectomy or angioembolization, and not splenectomy versus angioembolization. So I actually believe that angiography is a tool looking for an application in the management of splenic trauma. And I'm going to try and show you in my talk where we can apply angiography and embolization. Okay, there's no doubt that in any surgeon's working algorithm in an approach to a patient with a splenic injury is that if you are unstable, you need the operating room. If you are stable, you're going to be given a trial of non-operative management. We are talking about high-grade injuries. And if we look at the ASD classification versus the World Society of Emergency Surgery, we're essentially looking at grades 4 and 5. And according to the World Society of Emergency Surgery, it's grade 4 and 5, the stable patient. So my talk is essentially looking at these grades of injury. So there's no doubt the hemodynamically unstable patient who does not respond to resuscitation needs to go to the operating room, and he needs an operation. Also, minor grade injuries in patients who are going damage control surgery for some other cause of intra-abdominal bleeding should ideally have their spleen taken out as well. Because leaving a spleen in the presence of acidosis, coagulopathy, and hypothermia in someone on inotropes is not very safe. It could look very silly. You have to go back to remove the spleen after an hour. After an hour, the patient has been in the ICU. So these are some of the significant predictive factors for failure of non-operative management. And we know that when we fail managing a patient with a splenic injury, there's an increased cost and an increased mortality. And these are some of the factors: grades 4 and 5, the high grade injuries, patients who have the presence of hemoperitoneum, more than 250 moles on CT scan, increasing injury severity. Some people say 15, some authors say more than 25. I like to keep it simple, and anyone with severe trauma, by definition, the ISS more than 15. Increasing age, a lot of controversy, but we tend to be a little bit more vigilant with older patients. And if on the CT, the patient has a contrast blush. Now, what's the failure rate before angioembolization of spleens that we were trying to preserve? So if you look at from grade 1 to grade 5, it's 5, 10, 20 for the simple injuries, and significantly increases to 33 in the third, and 75% for grade 4s and grade 5s. And almost all the failures occur in the first 72 hours. So what are the indications for angioembolization in splenic trauma? So these are generally described as AAST grades 4 and 5, or WSES grade 3. Patients with moderate to large hemoperitoneum, as you can see on the CT scan here, or patients with contrast extravasation on the CT, either contained blush or free leak of contrast into the peritoneal cavity. So then what is the role of angioembolization in splenic trauma? So this is a study looking at the non-operative management of adult blunt splenic trauma. It's a meta-analysis with and without splenic artery embolotherapy. 33 studies, 10,000 patients, 2/3 of whom were managed non-operatively. So if you look at the failure rate for all grades of patients, it's about 8%. I prefer to read this as a more than 90% success rate in the management of splenic trauma. Then looking at grades 4, the failure rate without angioembolization is 43%. The failure rate with angioembolization is 17%. Grade 5 injuries, the failure rate without angioembolization is 83%, and the failure rate with angioembolization is 25%. And these both significantly increase the success rate of the management of splenic trauma. Now, there's this concept of, well, not concept, the radiologist either do a proximal or a distal embolization of the splenic artery. So proximal, we're looking at main splenic artery embolization, distal embolization of the smaller arterial branches within the parenchyma. And this is a very nice meta-analysis and review looking at the outcomes of proximal versus distal. And if you look at the complications of angiography, major complications are defined as those requiring intervention, usually in this scenario, splenectomy, or minor complications not requiring any surgical intervention. So the rebleeding rate from angiography and embolization is about 5 to 10%, and occurs more commonly with distal than with proximal angioembolization. Looking at major infarcts tend to occur more commonly with distal embolization compared to proximal, and the numbers are really small in this study, but the infection, there were about 4 patients who developed infection, and we're talking about splenic abscess, necrosis, complete infarction with secondary infection, and only 1 patient with distal embolization. So looking at the angioembolization technique, the very nice systematic review and meta-analysis looking at the impacts of different techniques, and a recent update on splenic artery embolization, it would seem that the current data definitely favors the use of proximal embolization and the use of coils or more permanent embolization techniques in adults. So this is an example of a patient we managed some time back. So this is a patient who's actually 2 weeks down the line who presents with a rebleed. So the repeat CT scan shows a very nice intrahepatic leak of contrast. And you can see in addition to that, his liver injuries also developed a subcapsular hematoma, which that eventually turned out to be a bile collection, a biloma, managed with percutaneous drainage and subsequently with endoscopic retrograde cholangiography and stenting. However, this contrast blush was managed quite nicely with angiography. You can see on the first run, there's a contrast blush, and then with our following intervention with coils, the aneurysm or the contrast blush has completely gone, is completely gone. So then exactly what is the role now of splenic angioembolization? I think Walt has mentioned or brought this article to your attention. I just want to dissect it a little bit more. So these were 23 studies, 3 prospective, 20 prospective, retrospective, and you can see quite glaringly there are no randomized control studies, looking at about 6,000, just over 6,500 patients, and they compared patients with undergoing non-operative management to those undergoing non-operative management with angioembolization. So what were the indications in these studies? Okay, for about 4 studies, they were performing angiography on patients with grades 3 to 5, 6 papers 4 to 5, contrast blush, large hemiperitoneum. Clinical discretion appeared to have had a lot of influence on determining who needed an angiogram, and no explicit indication in 7 of the articles. So you can see the indications, again, angiography looking for an application in the management of splenic trauma. Failure rates, again, previously mentioned, all grades, the overall failure rate was about 7%, up just under 8% for non-operative management, and just under 9% for patients undergoing angioembolization. The definition of failure was considered to be splenectomy, evidence of ongoing bleeding, or any further intervention that was required. And if you looked at grades 1 to 3, there was no difference. Looking at grades 4 to 5, there's a significant reduction or decrease in the failure rate. Morbidity was very high in the angioembolization group, and the complications included abscess, infarction, pseudocyst, pancreatitis, abdominal compartment syndrome, ARDS, multi-organ dysfunction, etc. Mortality, cited in 7 of the papers, 2,000 patients. The mortality was not much different, 4% versus 5%. Hospital stay, 10 days versus 11 days. Blood transfusion requirements, both groups, less than 2 units. So to summarize that article, you could see that the non-operative management failure rate, the mortality, the length of hospital stay, the blood transfusion requirements, there was no difference in the 2 groups. Overall morbidity actually increased with angiography and embolization. But when you stratify by grade, you can see that for grades 1 to 3, there was actually no effect. However, for grades 4 to 5, the high-grade injuries, it significantly reduced the failure rate. So clearly what is needed is a randomized controlled study looking at grades 4 and 5 with 2 arms. One arm in the non-operative management group and another arm, non-operative management group with angioembolization. Now I have looked very hard for a study on PubMed, on Google Scholar, etc. I could not find one. However, I believe there is a multinational or multi-institutional study ongoing in Europe at the moment from a group in Oslo. So I look forward to these results. So currently what we have then is that we have a CT scan that can grade the splenic injury for us. It can tell us how much of hemoperitoneum or the volume of blood in the peritoneal cavity, and tell us whether there are any parenchymal vascular abnormalities such as a blush. We have angiography and angiographic techniques, which can be either diagnostic or therapeutic. We have low-grade splenic injuries, and we know from the literature, some of which I presented to you now, there's no early role for angioembolization. However, if we're going to perform mandatory angiography for grades 4 and 5, there's clearly evidence shows there's no consistent improvement in outcomes. It does not ensure splenic salvage. And as Walter's mentioned, up to 40% of the patients who have a contrast blush on the CT scan, angiography actually can't detect anything. So then let's go back to our working algorithm. So if you have a splenic injury and if you are unstable, yes, you require surgery. If you're stable, we'll give you a trial of non-operative management. And let's add some meat to our algorithm now. So if the patient is unstable and is either a non-responder or a transient responder, has a positive FAST or DPL, clearly you need an operation. And then you have a whole lot of options with regards to what procedure to perform. You can do a splenectomy, a partial splenectomy, splenography, splenic artery ligation, mesh wrap, autotransplantation, etc. However, if you are stable or you are a rapid responder, you undergo a CT with intravenous contrast, and all patients with splenic injury should be given a trial of non-operative management. However, if there is a blush on the CT, one would then recommend or would say, yes, let's proceed to angiography in the stable patient, in patients who have blushes on the CT scan. So yes, angioembolization does have a role in the management of splenic trauma. However, it should be used as an adjunct and not routinely in any grade, or in particular people who advocate for grades 4 and 5, because it does increase the success rate in high-grade splenic injuries. Thank you.
Thank you very much, Pradeep, for your presentation. That is absolutely complementary to the WALTS 1.
Yes.
We have two questions from the same guy from the northern part of Italy. He is working in a very big and busy trauma center, Dr. Magnone. You can read in the chat. He asks, what's the role of non-operative management without angioembolization in grade 4 and 5 injury? And the second question is, what do you think about indication to the angio in grade 1 to 3 injuries without contrast blush or extravasation?
Okay, so I can see the question here. So what's the role of non-operative management without
Yes.
embolization in grade 4, grade 5 injury? So I'm not so sure what's the role of non-operative management. So in patients who present with grade 4 and grade 5 injuries, and if they are hemodynamically stable, and your CT does not show any contrast blush, and your patient remains stable without a drop in hemoglobin, without a hypotensive episode, and remains completely stable, I would not do an angiogram on that patient. However, if the patient does drop his hematocrit and requires a blood transfusion, but remains stable, I would then consider an angiogram again later. If the patient becomes hemodynamically unstable at any stage or requires more than 2 to 3 units of blood in a 24-hour period, I'll take him to theater and work his spleen out.
Perfect.
I like that.
Would you like to add something?
Yeah, I agree 100%. I was going to ask Pradeep what his thresholds were for going to embolization and then for going to the operating room, because I think everybody has a number in their mind about when they're going to take that next step. And, you know, the non-operative management without embolization in grade 4 and 5 injuries, the retrospective data suggests that there's an improved success rate, but the individual patient, there are so many nuances, and the finding on the CT scan, the drifting of the hemoglobin, if there was ever any evidence of shock, I think all those things play into the decision to do an intervention. And if there are associated injuries, like a brain injury, you know, I might go earlier to embolization if there are any of those things. And certainly, as Pradeep says, if they start to require a blood transfusion, if they are stable, I will embolize them, but I'm not going to transfuse 3 or 4 units of blood for a grade 4 or 5 injury and continue to manage non-operatively. I think that patient should go to the operating room.
other two questions regarding three questions. One is regarding the possible changing in indication to non-operative management or splenectomy in patients with splenomegaly and trauma. This is something that is peculiar. So there is another question regarding asking for the differences within the blunt and penetrating trauma. This is the tricky field. And regarding even the something similar to the first question, the spleen rupture in grade 4 and 5 in children, or both.
Okay. So let's take the one that I can read off the chat. It asks any difference between blunt and penetrating trauma, and if you perform a damage control procedure, what do you do? Okay, so we have a lot of patients in whom we treat non-operatively with penetrating trauma. I got to say, we only have a handful of patients with isolated penetrating splenic trauma that we've managed, and we manage them exactly the same way we do with the blunt trauma. So the indication for angiography, the indication for surgery would be absolutely the same. We don't treat them differently. However, it's a very, very, very small group of patients. I think we've got less than 10, 15 patients that we've managed as such. Then, when it comes to damage control procedure, there's no place for a splenic salvage procedure, okay? Whether it's a grade 1 or a grade 2, or it's a minor splenic injury, but you've got other major intra-abdominal vascular injuries, and the patient is coagulopathic, the patient is hypothermic, the patient is acidotic, the patient is on inotropes, you're going to take that spleen out. There's no place for splenic salvage procedures. I mean, those are finicky and they take a lot of time to perform. I mean, it's much easier just to whip the spleen out than to do a splenography or to do a partial splenectomy. And then there was something about a pediatric. I unfortunately don't treat pediatric patients. All my patients are over the age of 13 and weigh at least more than 50 kilograms. So I can't actually comment on that. Walt, you perhaps, I don't know if you treat it.
Yeah, I agree with your comments about the penetrating injuries and the damage control situation. I think in children, fortunately, I don't have to deal with children very much either, but I know from the pediatric surgeon's standpoint, it's all about hemodynamic stability in the children. Angioembolization really isn't something they do. And so if a patient's requiring 4 units of blood, they may go to splenectomy. But if they remain completely stable, they may continue to transfuse. But I think 4 units is a common trigger. You know, we never answered Stefano's question about the low-grade injuries. I really don't think there's a role for angioembolization without a contrast blush, and even with a blush in the low-grade injuries, I think it's not really supported by data. And Federico, you brought up the abnormal spleen. That is a difficult situation. I have not had great success. I don't have data to put to it, but non-operative management of the abnormal spleen is fraught, and they often fail. And if we embolize them, then they've got a big abnormal half-dead spleen, and it often causes problems. And the more embolizations you do, the more of these that you see, and they're kind of difficult to manage. They have a big inflamed spleen in the left upper quadrant, and often would have been better off with a splenectomy.
There is a comment or a question from Dr. Kobe, I think from Japan, but I don't know for sure. He asked, is there any surgeon who will go to angioembolization for unstable patients? This is a very tricky question. I may comment on this regarding, it depends on even I think on the possibilities of the hospital, because if you have something like an hybrid operating room, you can think to push forward the possibility to manage even patients that are not completely stable in a sort of attempt on non-operative management before the surgeon who is already ready to operate inside the room may operate on them. But this is something that you should comment on, but it's something, and maybe this will be the future of the trauma management, because even some papers, even from Cali, Colombia, Professor Ordóñez showed us that they perform almost routinely a CT scan in unstable patients, and they increase dramatically the rate of spleen salvage in even either penetrating or blunt trauma. But I think this is something that will be the future. At the present, we should give indication regarding the management in agreement with the literature, not with the single hospital protocols that may be more or less futuristic for some aspects. This is my, but I would like to know your opinion.
Well, I have, it seems from the literature that the Japanese are ahead of a lot of us in their ability to use hybrid rooms, to have them available, and to push the envelope with some patients. And there was a paper, and I don't know the person who asked the question, I don't know if they were involved, but a paper describing placement of Reboa catheters and high transfusion volumes and angioembolization to save spleens, which I think is an extraordinary use of resources to save a spleen. But if the availability is there, it may be reasonable to try the embolization in a hybrid room.
So it essentially boils down to your resources. If you have the facilities, if you have the team, if you have the hybrid theater, then yes, push the envelope and go for it. In my setting, if my non-operatively managed patient becomes slightly hypotensive at 2 in the morning, there's no ways I'm going to think about a repeat angiogram. It takes 2 hours to get the radiologist in, to set up the radiology suite. Much easier just to book the patient and take him to theater and take it out and then go back to sleep an hour later. You'll sleep much better knowing that a patient's not going to bleed again.
We can see from Professor Di Carlo a question regarding the possibility of autotransplantation of the spleen in high grade or when the spleen should be taken off. And would you like to comment regarding this possibility, regarding this idea, because Professor Di Carlo is setting a study, I know this, regarding the autotransplantation. So would you like to, do you have an idea, would you like to comment regarding this?
Okay, so those are splenic salvage procedures usually done in the hemodynamically stable patient. And if you could look, autotransplantation is more written about than is done. Personally, I've never performed an autotransplantation. And the whole idea why people want to do autotransplantation is this fear of OPSI in splenectomized patients. The incidence of OPSI in the trauma patient is less than 0.5%. I've never seen a single patient with overwhelming post-splenectomy infection. It's more common in patients with hematological disorders and more common in kids. So I'm not so sure OPSI actually exists in a young adult patient who has had a splenectomy. So we've never done autotransplantation. So I have no experience. So, but that's just my reason why I don't attempt autotransplantation, because we don't see OPSI. It's possible you could argue, yes, your patients are dying, going into the morgue, you don't see them. No, we would, those patients, we would hear about them. And I haven't seen a single OPSI in an adult patient who has a spleen taken out for trauma. I don't know, Walt, what's your experience with
Well, I was trained by Gene Moore, and that group in Denver had done research with autotransplantation for many years before I came on the scene. So, you know, back in those days, we would do splenectomies on patients who weren't so unstable. It was, you know, you do a diagnostic peritoneal lavage, there's blood. Actually, the first trauma laparotomy I ever did was with Gene Moore when I was a young resident, and we did a splenography because the patient stabilized. And so we just repaired the spleen. But we would do autotransplantation. And if we're in a situation where the patient's stable, I'll do it. And the residents always say, "What are you doing?" And the nurses say, "What are you doing?" And there was one paper in the Annals of Surgery 15 years ago or so that showed that the immunoglobulin response to vaccines was improved in patients who had had transplantation compared with asplenic patients. I don't know that the literature is that strong. And as you suggest, we're doing splenectomies only in unstable patients these days. So it doesn't really come up anymore. But it is, you know, it adds only 2 or 3 minutes to the procedure. And so if the occasion arises, I'll do it.
We have some comments from Professor Ball from Ireland who support the necessity to operate people unstable without trying to save the spleens, but risk to lose the patients for hemodynamically unstable. There is a question from Dr. Akapulu asking for the risk of OPSI in patient undergone to angioembolization, and the supporting from the United Emirates regarding the lacking of epidemiological studies regarding infections in adults. Would you try to answer regarding the risk of OPSI in patient undergone to angioembolization? It's a very difficult question to answer.
Well, I think as Pradeep said, I don't know of any patients who've had that problem. And it, you know, as far as the infections, it may not occur during the follow-up period, but you know, an older patient, if they're asplenic and they get to an older age, they may be more susceptible to pneumonias, and maybe more important, they're getting their vaccines every year. And that's why I think having some functioning splenic tissue may help those patients, but there's no data to support that or prove it.
This is just to answer even to the question regarding the necessity or the usefulness of vaccination after angioembolization. We have no data, we don't know, because some studies reported different indicators of the effect of angioembolization, the effect and the function of the residual spleen, but we don't know really which is the real residual function, and we don't know which is the necessity or if there is a necessity for vaccination. A lot of many protocols around the world use vaccination because they try to be protective, and so without knowing the real effect, they try to vaccinate as much people as possible in order to reduce the potential risks, but there are not calculated risks, so we really don't know, and we have no numbers regarding this. I don't know if you want to comment on this, but so we have no other question. So I think that we can try to summarize this really interesting and there is in patient who has had serial angioembolization and who remains clinically stable, is re-imaging indicated and when? From Dr. Chang Foot.
I don't think that routine re-imaging is indicated, but if the patient has leukocytosis or fevers or some symptoms, then they may have developed an inflammatory fluid collection or inflamed spleen or even a necrotic spleen. So I think imaging is indicated there.
Yeah, we don't have a protocol that requires re-imaging for any blunt organ injury that we manage conservatively. The patient's repeat CT will have to be, the patients will need So what I'm saying is there need to be an indication, as Walter said, suspicion of infection or rebleeding, then we will re-image. But we do not re-image if the patient is asymptomatic, irrespective of the grade or whether the patient has had angioembolization, unless there's a symptom, unless the patient becomes symptomatic and there's an indication. Otherwise, we don't perform any repeat imaging.
There is another question from Professor Ansaloni from Pavia. What do you think about the use of intraoperative embolization in order to increase the spleen salvage rate? This is interesting opening in discussion. Possibility to use the angioembolization inside the operating room in order to save the spleen.
Oh, if you got the resources and you got the facilities and you got the time and the patience, yeah, go for it. Otherwise, not for me. Thank you. It depends on your resources and whether you have the time and the facilities. Absolutely, it's an option. But personally, if I'm in that belly, no, it's going to come out.
I agree with that.
So, at the end, we can say that both techniques are complementary, so should be used together, but trying to not push too much forward in order to try to save a spleen and maybe risk to lose the patient or to waste a lot of resources. Because even if we work in a very rich hospital, we should not waste resources at all, even in that situation, especially if our hospital is not so rich. And especially maybe in a period like this, in which we are really stressed from the systems are really stressed from even the pandemic events. So we have to focalize and to optimize resources and interventions. So maybe it would be better to lose one spleen more than to lose one patient or a lot of resources, because at the end, spleen can be even replaced by vaccination and by other drugs. So maybe I think we can summarize the two interventions in this way. I don't know if you want to comment.
Yeah.
Massimo, do you would like to?
I have to say that there is no a winner, but the presenter defend their position in a very appreciable manner. And I personally agree with both the conclusions, but that are not conflicting. There are some common points. If I will synthesize the session by saying that NOM and angioembo could save the spleen, but once you go straight to the theater to do laparotomy, and this happens because the patient is unstable, or because the non-operative management, either with or without angioembo fail, that is the time to do splenectomy. Because if I'm not wrong, I believe that in that situation, the patient need to have a splenotomy for saving his life. And perhaps there is no more room for procedure aiming to splenic preservation, like splenography or wrapping of the spleen. To tell you the truth, who is doing nowadays wrapping of the spleen? That's all. Do you agree with my synthesis?
Yes, agreed.
Thank you, Walter. You are a friend.
Completely agree.
Yeah.
Okay, guys, thank you very much for being here with us and for presenting and discussing with us and teaching to all of us these important things. And hope to see you in the next meetings. I have to tell you that we had more than 130 people connected to this meeting, so a lot of people. And I know for sure that in many places in Italy, but maybe even around the world, they have one connection for almost 10, 15 people, because they have rooms in which they connect all together for residents or other guys. So I think that we have a great result with this this conference. Thank you to your presence, because you were the big guests of these conferences. Thank
Well,
you very
thank
much,
you.
even to
Thank you.
everybody.
Thank you for putting it together. This is great for the world and our colleagues around the world, and it's a wonderful thing that you have done to organize this. So thank you.
Okay.
From your side and my side as
Ciao,
well, thank you
ciao.
very much. It was an absolute pleasure. Thank you very much.
Ciao, ciao.
Thank you, guys.
Ciao.
Bye.
Cheers, Walt. Cheers, Federico. Cheers,
Bye.
Massimo.
Ciao.